Hello everyone, welcome to HIM 225. This is a continuation of the lectures covering Chapter 17 in your textbook. On page 408, let's start by looking at the influenza guidelines. And there are influenzas that we can only code if they are confirmed cases. And these fall into category J09 and J10. So let's take a look at these. So these are the influenzas that are documented as being novel, influenza A, and we can only apply these codes when we have confirmed documentation. And these are things like avian flu, bird flu, swine flu. And when we're talking about these, if the physician documents possible, probable, or rule out, they cannot be coded. So this is an exception to that guideline that says anything that's possible, probable, or ruled out is coded as though it is. In this instance, for these two categories, that is not the case. When we look at the category of J10, these are additional types of influenzas that have to be confirmed before they can be coded. This guideline tells you that confirmation is based on physician's documentation, so you don't actually have to have a positive lab value to assign these codes. In the index, I wanted to show you influenza. You can see that the default code is J11.1. There are different types of manifestations that have specific codes as well. And then I wanted to show you those entries that fall into the J9 and J10, or J9 and J10 categories. So for instance, A codes to J10. A H5N1 codes to J9. B and C code to J9. Avian, and then identified influenza avian also codes to J09, but if it's identified influenza virus NEC, J10.1 with, and then these digestive, the various effects on different systems have specific codes. So you can see that there are not a lot of entries for influenza, and we'll look at J11. We can see that this category is influenza due to unidentified influenza virus. And these are the three categories that we have related to influenza as we look at the category list: influenza, J9, 10, and 11. The next codes that we're going to look at here real quickly are the pneumonia codes. And I want you to notice that we have some specific categories here. We know that J18 is pneumonia unspecified. We've coded that quite a bit. But we can see that there is a specific category for a viral pneumonia, pneumonia due to streptococcus, pneumonia due to Haemophilus, bacterial pneumonias, other infectious organisms. Pneumonia and disease is classified elsewhere. Let's take a look at that one real quick. And when we look at this category, you can see that we have a mandatory instructional note, code first underlying disease, such as Q fever, rheumatic fever, schistosomiasis. And then we have an excludes note 1. And it's an excludes note 1 because of all of these other type of pneumonias actually have a specific code. So we would not be coding those in category J17. I want to go to pneumonia. And this is in the index. We're looking at pneumonia. Here's our default code, which we've looked at before. And then you can see that these are all the other types of pneumonia. For instance, we have aspiration pneumonia, due to, and then all the types of things that could cause an aspiration pneumonia. Pneumonias of the newborn, we'll actually study those more closely when we're studying that chapter in ICD-10. And then you'll notice that we have bronchopneumonias, and then there are also congenital pneumonias. And then I want you to notice that different bacteria are also being listed here. For instance, E. coli pneumonia, J15.5. This is a code that is a combination code. It includes the pneumonia and it also includes the organism of E. coli. We would not apply an additional code for E. coli because it's actually included in the description of this pneumonia. We can see there that we have an unspecified bacterial pneumonia code, and you will sometimes see physicians document bacterial pneumonia without necessarily telling you what the bacteria is or without any cytology from the lab to show you what the bacteria is. We've heard of staphylococcal pneumonia and Staph aureus pneumonia, MSSA or MRSA. These are in category J15. And again, these are combination codes, so we're not going to add an additional code for an organism because it's included in the description with this code. And then we also have streptococcal pneumonias as well. So when you're coding pneumonias, make sure you look through the index carefully to find your code. Let's look at this third example on page 408. Patient was admitted with a confirmed case of avian influenza. And of course we can go to influenza, avian, and we can find that code J09.X2. X, of course, we know that that is a placeholder, and we verify it in the tabular. Patient admitted with possible H1N1 influenza. And the key here is that this is possible, but H1N1 has to be confirmed. Has to be a confirmed diagnosis to code it, so we would just be using the default code for influenza, which is J11.1. Now the next guideline concerns ventilator-associated pneumonia. So this tells us, as with all post-procedural complications, the assignment of the code is based on the provider's documentation and the relationship between the condition and the procedure. So in this instance, this pneumonia is specific to a patient on a ventilator or a patient who has been on a ventilator and develops pneumonia because they were on the ventilator. So the code for this is J95.851. It should be assigned only when the provider has documented that the patient has ventilator-associated pneumonia. And then we also use an additional code for the organism. And you can see that we do have an instructional note here that says use additional code to identify the organism if known. And that's always going to be a B code. And we'll look at those in just a minute. We would not assign codes from categories J12 through J18 to identify the type of pneumonia if it is specifically a ventilator-associated pneumonia. So this code J95.851 is not assigned for cases where the patient has pneumonia and is on a ventilator and the provider has not specifically said that the pneumonia is a ventilator-associated pneumonia. So you can't make the assumption that just because a patient has pneumonia and is on a ventilator that it is ventilator-associated pneumonia. The physician has to document that. Now, a patient can be admitted with one type of pneumonia, and the example in your book is pneumonia due to streptococcus, and then subsequently develop ventilator-associated pneumonia. When this happens, the principal diagnosis would be the appropriate code from category J12 through J18 for the pneumonia that was diagnosed at the time of admission, and then the code J95.851, the ventilator-assisted pneumonia, the VAP pneumonia, would be assigned as an additional code when the physician documents that, in fact, that is what the patient has. So that I strongly encourage you to carefully read the physiology and the conditions that are covered in the rest of this chapter. Your question for this lecture is going to be from exercise 17-2, question number 5. I would like for you to answer that question and submit this assignment. I also want you to take a look at the Z codes that are associated with this particular chapter in ICD-10, Chapter 10. Those are listed for you on page 421. And then when we get into procedures, mechanical ventilation is a procedure commonly associated with pneumonia. We looked at those codes in the procedure index, and those codes are based on the amount of time that the patient is on the ventilator. And when you're calculating that time, typically what we always did was we actually went to the respiratory therapy notes. And you calculate time on the ventilator from the time of intubation to the time of extubation. In the index, I went to mechanical ventilation, and it takes us to a table in extracorporeal assistance, and you can see that for the duration, we have options of single, and then less than 24 hours, 24 to 96 hours, and then greater than 96 consecutive hours. And one of the reasons that this is so very important is because this particular code impacts DRG assignment and the DRG weight for a patient who is on a ventilator in each of these time frames impacts the reimbursement. So greater than 96 hours has the greatest reimbursement, then 24 to 96, and then less than 24. So that's one of the reasons that you have to carefully look at patients who are on ventilators and make sure that you get that time accurately reflected with the code. Another procedure that's commonly done is a bronchoscopy, and this can be done as an inpatient. Sometimes it's done as an outpatient. And you see that when you look up bronchoscopy, it goes to the root operation of inspection. And it's very important to note that if anything other than an inspection is done, that you actually have to code it to that procedure. So for instance, if they do a bronchoscopy with a lung biopsy, we know that that is going to be an excision. That operation changes from inspection to excision, and then it's of the lung, and then of course we have to choose the appropriate table based on where the lung biopsy is performed. Another procedure that can be done is a thoracentesis, and this is when they drain the pleural cavity. And so going to this table, um, we would actually choose, let's say, pleural cavity right, and typically it is percutaneous. They just pop a needle in there, drain the fluid. They sometimes they may leave a drainage tube in there, but usually they're withdrawing the fluid for diagnostic purposes, so it would be no device, but it would be diagnostic because they're draining that fluid to send it in for evaluation. They want to see what's going on, why this fluid is accumulating. Unfortunately, a lot of times it's because the patient has cancer. A tracheostomy can be done so that an airway can be accessed. And in the index, basically you look up tracheostomy and it brings you to the table. Typically a tracheostomy is open and a tracheostomy device is inserted, and it is cutaneous because it is coming through the skin. In your textbook on page 427, it talks about pulmonary resections. And the important thing that you have to remember about pulmonary resections is that each lobe of the lung is considered to be an organ. So if a lobe is removed, it is considered to be a resection and not an excision. However, there are times when wedge resections are done, and if a wedge resection is done, it's actually not a resection, it's an excision because just a portion of that lung is being removed. But if, in fact, the entire lobe is removed, that is considered to be a resection. So anytime there's a lobectomy, that is a resection. And if we, in the index, if we go to resection lung, then you can see the different lobes that may be resected or removed. And typically this procedure is an open procedure, and there's no device and no qualifier. This will conclude your lecture covering Chapter 17. The next lecture will actually cover the homework for you.